Okay, so after taking fever with rash, I am continuing with typhoid fever, another infectious disease called the Salmonella typhi. And here there are two types, typhoid and paratyphoid fever. And ICD has given different numbers to them and typhoid fever. So typhoid, it means typhus, smoke or cloud that was believed to cause disease or madness, came from the Greek word. So what is typhoid? Result of systemic infection which is called as typhi, and it is clinically characterized by a typical continuous fever for 3 to 4 weeks with relatively bradycardia, involvement of intestinal lymph node, reticuloendothelial system and gallbladder. So if we call enteric fever, it includes both typhoid and paratyphoid fever. So what are the epidemiological determinants? It can be agent factor, host factor, environmental and social factor, incubation period, and mode of transmission. If we talk about the agent factor, the host, typhoid fever is mainly caused by bacterium, Salmonella typhi from the family Enterobacteriaceae. Salmonella paratyphi A and B are relatively frequent. The bacteria grows better best at 37 degrees Celsius. So if we come to the antigenic structure of the Salmonella, it is divided into somatic O antigen and flagellar H antigen. Somatic or O antigen contains long chain polysaccharide comprises of heat stable polysaccharide commonly. Flagellar or H antigen are strongly immunogenic and induces antibody formation rapidly in high titers following infection or even immunization. The flagellar antigen is of a dual nature occurring in one of the two phases. So the specific one is O antigen. These are peritrichous flagella, color pink, therefore they are gram-negative. Reservoir of infection, human is the only reservoir case. We define the definition of cases and carriers. A case is infectious as long as the bacilli appears in the stools or the urine. It can be mild, mild or severe. If we talk about the carriers, they can be temporary or incubatory, which excrete bacilli for 3 to 6 long weeks. Chronic carrier can be those can excrete the bacilli for more than a year. Example is typhoid Mary, real name Mary Malone. Now coming to the source of infection, the primary source can be feces or urine of a case of a carrier. Fecal carriers are more frequent than urinary carriers. Secondary infections, they may be contaminated food, water, fingers, or flies. So how does the bacteria cause the disease? The pathogenesis of typhoid. So first, anything that is swallowed by bacteria is swallowed by food, mouth, fingers, or flies through the flies, and it just goes to the anthrocyte lining the terminal ileum and then to the pair pages leading to the inflammation of the mesenteric lymph node with the primary bacteremia, and then leads to primary bacteremia leads to seedings at the reticuloendothelial system, liver, spleen, gallbladder, and bone marrow with the widespread secondary bacteremia. So ingestion of the contaminated food invade the small intestine, carried by WBCs to the liver, spleen, and bone marrow. Multiply and re-enter the blood to go to secondary bacteremia. Bacteria then invade the gallbladder, biliary system, lymphatic tissue, and bowel and multiply in high time numbers, then pass into the intestinal tract and can be identified by a diagnosis and the culture in the stool test in the laboratory. Now coming to the host factors, age occur at any with highest incidence in between 5 to 19 years of age group. It is more common in males than females. Carrier rate is more in females. If we talk about the immunity, antibody may be stimulated by infection or immunization. Antibody against O antigen is higher in patient with disease and antibody against H with immunized person. Coming to the environmental and social factor, typhoid fever is regarded as the index of general sanitation in any country. You have also must have read in the PSM. It usually, the incidents are more in July to September. Outside human body, bacilli are found in water 2 to 7 days, soil irrigated with sewage 35 to 70 days, in ice cream and ice over a month. Food multiply and survive for some time. Milk, it grows rapidly without altering its taste. So this is very important. Now coming to the incubation period, usually it can be between 2 weeks to or as long as 3 weeks, depending upon the dose of the bacilli ingested, mode of transmission. Feces and urine from cases or carriers go to the water, soil, flies, and fingers, and then it is eaten raw or cooked and ingested by the person. Clinical features, are according to weeks, first week, second week, third week, and rare complication. In the first week, the symptoms are usually not very specific. The patient may present with malaise, subtle symptoms, headache, cough, sore throat in prodromal stage. The disease classically presents this step-ladder fashion, but this is usually not seen in younger children. Constipation alternate with diarrhea can happen, and the diarrhea is typical pea soup diarrhea. In the second week, we can see hepatosplenomegaly on examination, and it usually happens second week between 7th to 10th day of the illness. With now the symptoms usually appear of the typical typhoid, with relative bradycardia may occur and rose spots may be seen. In third week, the patient will appear in the typhoid state. This is a dreaded complication that usually occurs in the third week, with perforation of the intestine can occur. Patient may go into the encephalopathy. Other rare complication can be hepatitis, pneumonia, thrombophlebitis, myocarditis, cholecystitis, nephritis, osteomyelitis, and psychosis. In 2 to 5% patient, it may become gallbladder carrier. So usually typhoid is multisystemic disorder or disease or infection, as it is affecting all the organs. So these are the rose spots, which is the characteristics of typhoid fever, but it is not seen in all patients. So you can see here the pink pupil 2 to 3 mm on drug, fade on pressure, disappear in 3 to 4 days. Now coming to the various complications. It can be meningitis, severe bronchitis affecting lung. It can affect the blood in the form of hemolytic anemia, venous thrombosis. It can affect the heart in the form of myocarditis, lungs in the form of lobar pneumonia. There is a term called typhoid nephritis, and it can also cause peripheral nephritis. So as you can, it is a multisystemic disease. Now coming to the major surgical complication, it can cause peritonitis, typhoid spine, paralytic ileus. This is most common complication. Pyelonephritis, cystitis, intestinal hemorrhage, and leading to the perforation, typhoid arthritis, osteomyelitis, orchitis, intestinal perforation, as I told you, typhoid cholecystitis, empyema. Excuse me. Now coming to the diagnosis, it can be microbiological, serological, or new diagnostic test. Microbiological procedures. So if we talk about the detection rate of the bacteria, first week in 90% cases you can take from the blood cultures, but second week 75%, third week 60%, and fourth week and later 25%. Bacteremia occurs early in the disease, so in first week you can get the positive blood cultures in 90% of the cases. So this is the McConkey agar where the salmonella is grown. And another serological procedure where we see the titers of the antibodies to O and S and antigen disease Felix Vidal test, but it is not specific. Other tests are typhoid.am antibodies test. These are antibodies, and other are IgM dipstick test. Now coming to diagnosis, this was the diagnosis of the cases. Now coming to the diagnosis of the carriers. It is useful in public health purpose, useful in screening food handlers, cooks to detect carrier state. Typhoid bacilli can be isolated from feces or from bile aspirate. Detection of VI agglutinins in the blood can be determinant of the carrier state. Now coming to the prevention or control of the typhoid fever, the main is the control of the sanitation, and as it is the index for the sanitation. Immunization is very important, control of the reservoir cases and the carriers. So in cases, early diagnosis by culture and blood culture institute should be there, notification done where it is mandatory. Isolation should be there till 3 negative tests, treatment by appropriate antibiotic, disinfection of the patient's stool and urine by 5% Lysol for 2 hours and closed by 2% chlorine. Follow-up examination, stool and urine at 3 to 4 months and at 12 months after discharge, because relapses are there. Now coming to the management, proper management of typhoid fever. First is the general management and the specific management, which include antimicrobial antibiotic therapy. In general measurement, you have to see the nutritional support, supportive care, maintenance of adequate hydration, and antibiotics. So treatment of uncomplicated enteric fever, we usually use third generation cephalosporin like cefixime, and the duration of treatment is usually ranges from 14 to 21 days. If there is resistance, then azithromycin can be used. For severe enteric fever, ceftriaxone can be used. In case of resistance, chloramphenicol and aztreonam. Now, carriers identification by culture and serological examination, treatment by intensive course of ampicillin and amoxicillin, which usually ranges for 6 weeks. For carriers, you have to treat for a long 6 weeks, that is 1.5 months. Surgery is usually for the carriers like cholecystectomy if needed, kept under surveillance, and health education is important. Control of sanitation, this is very important. Protection, purification of drinking water. Drinking water purification is very much important, which causes many diseases and carrier of many diseases, including hepatitis. Improvement of basic sanitation and promotion of food hygiene. No raw food should be eaten. Hand washing, it is the best prevention. You should know the 7 steps of hand washing. Immunization, vaccinations are recommended. There are 3 types of vaccine: injectable, typhoid, and live oral and TAP vaccine. Injectable typhoid vaccine, Typhoid VI vaccine. It is given IM, efficacy of 64 to 72%, used over the children of 2 years. It is mainly polysaccharide, single dose. Typhoid oral, it is live attenuated. Efficacy rate 50 to 80%, usually given children less than 6 years of age. It is not recommended for the children in the less than 6 years of age. So it can be given to children more than 6 years. Okay. The course consists of 1 capsule orally taken an hour before food with a glass of water or milk. It is usually not used nowadays. Nowadays, we are using typhoid conjugated vaccine. This is polysaccharide vaccine. So that's all about the typhoid. Now, continuing with another topic, we are going into rhinology or urology. So I will be taking UTI followed by ARF and CRF. So UTI, these are the questions. Now coming to the introduction and epidemiology, urinary tract infection, as the name suggests, it is the infection of the urinary tract, including kidneys, ureter, and urinary bladder. Among the commonest bacterial infection diagnosed in childhood. Before the age of 1 year, boys are more likely than girls to acquire UTI. In younger children, anatomical abnormalities are the cause for the UTI. After 5 years, voiding dysfunction are the etiology. It includes 10% of all febrile children, and the uropathogens, if we say, mainly gram-negative organism, E. coli in 85% of the cases. Now, how to approach a case of UTI? So, first we will define, then we will suspect and plan investigation accordingly, manage and tell the prevention. Definition, it is the infection of urinary tract by the growth of significant number of organisms of a single species in urine in the presence of symptoms. So there should be a symptom, there should be a species of single organism in growth. How to suspect any febrile infant, male less than 1 year and female more than 1 year. Predisposing factors like bladder bowel dysfunction, neurogenic bladder anatomical malformation, voiding dysfunction, clinical signs of upper and lower urinary tract involvement, severity of illness. Types, it can be significant types of UTI, significant bacteriuria we call when there is more than 10 to the power 5 colony forming units in the single species in midstream clean catch. Asymptomatic, where you will find the bacteria but without symptoms. Recurrent, any second episode is called recurrent UTI. Now, according to treatment, how we progress with the treatment, we have divided for our convenience it into simple and complicated UTI. Simple UTI, It usually presents with low-grade fever, dysuria, increased frequency, urgency, and absence of complicated UTI symptoms. Complicated UTI, it presents with fever more than 39 degrees Celsius, systemic toxicity, persistent vomiting, dehydration, renal anger, tenderness, and there will be deranged renal function test. Coming to the symptoms in infancy, there will be non-specific symptoms like poor feeding in 1 to 5 years. He can tell you about the abdominal pain or increase in frequency. Rest includes fever, vomiting, voiding problems, reddish urine, dysuria, cloudy urine, urgency, or offensive urine. Now, how to collect the sample and what is the interpretation? Is by suprapubic aspiration, even a single pathogen colony is give the probability of infection to 99%. Transurethral catheterization, 50,000 colony forming units, and midstream clean catch, as I told you, more than 10 to the power 5. How to collect and preserve the sample? The collection of the sample should be done under all aseptic precautions, not from the bag, urinary bag. If you are using a urinary catheter, by suprapubic, as I told you, if you are not able to transfer the sample directly to the lab, then you have to keep it between 4 to 8 degrees Celsius. You should wash the genitalia properly with soap and water before collecting the sample. Now, the gold standard for the diagnosis is urine culture. Other tests also are there in the market, like deficit test, which include nitrate positive, leukocyte esterase positive, but with the combined specificity and sensitivity. Now, coming to the role of imaging indications at high risk of renal damage, especially if the child is in infancy period, then the role of imaging is there. Any child presenting with BUR or obstructive uropathy, if there is some abnormality in the antenatal USG, and to identify upper urinary tract involvement. Different imaging modalities are DMSA, USG, MCU, and DTPA. Now, if there is a first episode of UTI, what you should do in different age group? If the patient presents to you during infancy, then you have to do all the investigations to rule out the UTI as early as possible to delay the progressive renal scarring. So you have to go through the all possible tests, including USG, MCU, and DMSA. If the patient is coming within 1 to 5 years after infancy till 5 years, then you have to go for USG or DMSA. If any of these are abnormal, then you can go to the MCU. More than 5 years, you can go for the USG first. If there is abnormality, you can go for other tests. If the patient is coming to the second time, it is labeled as recurrent UTI at any age, and he should be evaluated with all of the investigations, imaging, including USG, MCU, and DMSA. So what is one more term which is frequently used is significant pyuria? It means more than 10 leukocytes in uncentrifuged sample or more than 5 in centrifuged sample. Now, coming to the management, what are the general measures? There should be adequate oral intake, or proper hydration, avoid constipation, frequent voiding of the urine to avoid cystitis, toilet training with BUR, violational low pressure, and voiding with double emptying or complete bladder emptying. Now, coming to the treatment, it depends on the clinical condition. If the child is less than 3 months febrile with complicated UTI, you have to give parenteral antibiotic for 15 days, 10 to 14 days. Less than 3 months with lower UTI, parenteral 7 to 10 days. More than 3 months with upper UTI, IV antibiotic for 1 to 2 days, followed by 10 days oral antibiotic. If there is more than 3 months with simple UTI, oral for 3 days. Breakthrough UTI, as per culture, we have to modify and give the antibiotic for 7 to 10 days. Asymptomatic bacteriuria requires no treatment. So what are the antibiotics that are used? Parenteral, we use ceftriaxone, Taxim, amikacin, and gentamicin. For oral, there is cefixime, coamoxiclav, ciprofloxacin, ofloxacin, sulfalixin. Now the choice of antibiotic for prophylaxis, cotrimoxazole, nitrofurantoin, ciprofloxacin, which is safer in children, and G6PD deficiency. Now, something about the BUR, vesico-ureteric reflex. As the name suggests, it refers to the reflex, that is retrograde flow of urine from bladder to the upper urinary tract, and it transmits the intravesical pressure freely to the ureter, then renal pelvis, then collecting ducts and renal tubules. It is the major risk for pyelonephritis and reflux nephropathy. So these are the grading. As you can see, the reflux in grade 1, it is into the non-dilated ureter. Then in grade 2, it is into the pelvis and calyceal system without dilatation. There is no dilatation, though the reflux is there. In third degree, mild to moderate dilatation of the ureter, you can see renal pelvis and calyceal system. In fourth, you can see moderate dilatation of both the system, and in 5, there's a gross dilatation. For diagnosis, by contrast, MCU or isotope radionuclide cystography, mainly we use MCU. So duration of treatment, as I told you, prophylaxis, so it is given here. If the UTI is below 1 year of age, in VUR cases, till the imaging is done, you have to give the prophylactic antibiotics. If VUR is grade 1 and 2, till 1 year, 1 year you have to give. But again, if the patient comes to you, then you have to start according to the culture the antibiotics. In grade 3 and 4, आपको देना ही देना है till 5 years of age, or if there is bowel dysfunction, bladder bowel dysfunction. Now, if such a patient comes for the follow-up, we have to analyze the urine, take the BP, anthropometry for growth and development, urine culture in the presence of symptom, a USG and cystography every 12 to 18 months. So to conclude, treatment of febrile UTI in young children should last for 7 to 14 days. Appropriate workup includes renal USG, MCU, DMS, and DTPA scan. So these are the questions for the students at the end of my lecture. Thank you.